Hello everyone and good evening. Welcome to the Health and Wellbeing Board, Wednesday the 7th of May. I'm Councillor Lucy Steels-Walshaw. Welcome everyone. And I just wanted to say, since the new terms of reference were approved at full council, a welcome to some new people on the board. So we should have Pauline Stutchfield, who is Director of Housing Communities at City of York Council, but unfortunately she's had to send apologies today. And Matthew Walker, Deputy Chief Fire Officer, additionally has had to send apologies. And also a welcome to Anya Haysbrook and Michael Ash McMahon, who's also at the back, who will be in for the next few meetings in place of Sarah Coltman-Lovell. So I think that is the new welcomes. To move on to apologies for absence, I'll just add we've got Matthew Walker, from the Fire Service, Fiona Wiley and Tim Forber from North Yorkshire Police, Simon Morritt from York Hospital has sent apologies, and Lucy Brown is substituting. Pauline Stutchfield has sent apologies, and Zoe Campbell from Tuve has sent apologies, and we have David Kerr here as her sub. Thank you. Does anyone have any declarations of interest? Nope. Okay. And then we're going on to the minutes of the last meeting on the 19th of March. Now, Councillor Runciman has made us aware that on page 15, there is a sentence that stops halfway through. If anyone can remember what that was or the sentiment around that, that would be great. Otherwise, we can watch back on the YouTube. So other than that, did anyone else have anything else to raise from the minutes? Nope. Okay. So if we move on to agenda item number 4, public participation, we have one person registered to speak, and this is Flick Williams, who will speak remotely on agenda item 7 in relation to the proposed disability benefit cuts on health inequalities. Are you there, Flick?
Yes, good afternoon.
Good afternoon. So you have 3 minutes. You've done this many times before. You don't want a warning, is that correct?
Correct, thank you.
Okay, thank you. If you'd like to go ahead.
Whether we are measuring life expectancy or healthy life expectancy, what is startlingly clear is that the government's proposed cuts to social security are taking us in the wrong direction. Don't be fooled by the spin that this will affect relatively few people. FOI requests to the DWP have revealed that with the change to the 4-point rule for PIP, 87% of those on the standard rate will lose it, effectively eliminating it altogether, and 13% of those on the enhanced rate will lose it. A total of 1.3 million disabled people will be affected. Loss of daily living PIP leads to loss of passporting for other help, such as the health element of universal credit and carers allowance. Unpaid carers contribute 184 billion annually to the UK economy. For those who lose it, requiring them to work to survive, the people they care for will still need care, and these will be the people arriving on the doorstep of social services and the NHS. PIP is supposed to cover the extra costs of being disabled. In reality, against the backdrop of an out-of-control rises to the cost of living, many are already using it to survive and are barely clinging on. If it goes, many will be unable to continue to live independently. How are your systems and services preparing for the tsunami of need that is coming your way? Yesterday's Guardian reports the government position in light of their drubbing in recent elections is to go harder and faster, suggesting a further 15 billion worth of cuts to benefits coming in the autumn. Last week, a group of disabled researchers met with Minister Stephen Timms. It's clear to us that the government doesn't understand either the system it administers or the knock-on effects of what they propose. Instead, they hold a quasi-religious belief that welfare recipients are made dependent by the support we receive, not by our chronic illnesses or impairments, our barriers to getting or keeping work in an ableist society, or the fact there are no jobs or employers willing to hire us, even if we are well enough to do them. The cuts to the Access to Work programme announced yesterday further confirm this is not about work. It is about cost cutting and punishment for things over which we have no control. We see the race to legislate for assisted suicide in tandem with cuts as no accident. It is the product of eugenicist mindset. The reports are now mounting up as to the devastation to the lives of society's already most disadvantaged that is coming. See those from Joseph Rowntree Foundation, the Trussell Trust, Amnesty International and Health Equity North. Poverty, food insecurity and housing instability come at the cost of even worse health outcomes. It is a doom loop that already sick people will not survive. With legislation planned for next month, the window for opposition is closing. Thank you.
Thank you, Flick, and we will take those comments into account at, sorry, agenda item 7. I did want to add that we did raise this in full council, and there is support that from the leader that the council will be writing to the government to make it clear that we can't manage making cuts to the most vulnerable people and leaving people who are in need of support without support. As a council, we are committed to supporting those in need and not putting other services under greater pressure. Thank you. Okay, so if we move on to agenda item number 5, an update on the drug and alcohol partnership strategic priorities, I'd like to invite Ruth Hine and Peter Roderick to the table. We have 15 minutes for this item, which includes presentation of the report and questions. And yeah, if you'd like to. Thank you, Ruth.
Thanks, Chair. I'm going to kick us off. That's right, really briefly, and then Ruth is going to overview the paper. So the reason that this board is receiving this particular report is that in 2021, there was a national review of services around drug and alcohol provision by Dame Carol Black, which found that services were very stretched, had been reduced in size, but also some of the changes to the drug market supply and the demand for drugs and some of the criminal justice elements of the drugs and alcohol system have essentially not been responded to in terms of the way public policy is set out. And so since then, there's been quite a lot of focus on particularly local authority public health teams in commissioning in a different way and some more resources in which to do that. And another, I guess, sort of more sort of human side to it is that drug and alcohol services and the way we treat people with addictions in society for a large number of decades has had quite a significant element of, I guess it's fair to say, sort of despair about it. People often left within a system and assume that they will stay in a certain place with their addictions for the rest of their life. And over the last 10 years, there's been a much greater emphasis on recovery and what recovery looks like in terms of recovery-oriented systems rather than purely simply treatment systems and keeping people in a certain place. Because of that, the Carol Black report then gave a bit of an impetus to local authorities to set up these things that they called combating drugs partnerships. And for us in York, we felt that was a little too focused on the drugs element of it, and we've called our partnership a York Drug and Alcohol Partnership just to make it a bit friendlier. That partnership doesn't formally have a home within the governance structure. Health and Wellbeing Board, we're not using the concept of subgroups anymore within our governance. However, it is the most appropriate place to bring updates on what that partnership is doing. I'm the SRO for that, the Senior Responsible Officer, and chair that partnership. And so what we brought before the board is just a bit of an update, particularly at the moment in the cycle of that partnership where we've been developing some strategic priorities, working to what the government have been asking us to do, and as well as some of the technicalities of it, I'd like the board to just be aware of that more human aspect of the move from treatment systems to recovery systems. Some really great stuff and some things happening in York around physical buildings and around recovery communities, which I think is there to be really celebrated, but we absolutely need to integrate it into the rest of the work we do. So I'll hand over to Ruth. She's going to describe a little bit about what that looks like locally, and then we can open for discussion.
Thanks, Peter. So as Peter already mentioned, the idea of this was to set out our priorities for 25 and 26, bearing in mind that it's a snapshot in a strategy that goes really through to 28. So the background is that the priorities have been built from that 10-year strategy from harm to hope, and it laid out these ambitions to reduce harm and death caused by drug and alcohol use. So locally, since the publication in 2021, we've established the York Drug and Alcohol Partnership, which started in 2022 and it's chaired by Peter. We've developed the health needs assessment, which has also then had some other reports, which includes the drug-related death review, insights from lived experience, and most recently, voices of young people, experiences with drugs and alcohol. We've received additional funding through the Drug and Alcohol Treatment Recovery Improvement Grant, which is the national grant that all local authorities have got. And for this year, we've got £450,444, which is also the same as our amount last financial year. So the annex that was added to the paper sets out the priorities for this year, which the Drug and Alcohol Board has proactive oversight of ensuring that local organisations work together and jointly agree the provision and areas to be improved. So, like I said, the information we've had through the other reports helped feed into that, along with other data that we've collected. Each priority area fits into the National Outcome Framework, and they focus on 3 strategic outcomes: so reducing drug use, reducing drug-related crime, and then reducing drug-related deaths and harm. 3 intermediate outcomes: reducing drug supply, increasing engagement in treatment, and improving recovery outcomes. York also decided through the various collectives at the table that actually mental health was really important, and therefore we have also added a 4th outcome, which will also be looked at this year, which is improved mental health. So page 3 of the document has the overview of the monitoring measures across all of those strategic outcomes. And the rest of the document demonstrates the local priority objectives at each area with specific measures, bearing in mind these are the specific ones for the year. It's also noted in the document that there is a lead organisation delivering against each objective, and it's their responsibility then to feed back within the board with progress. And again, each area, we decided just to focus on 2 objectives rather than trying to achieve too much, and actually focus for the year to really hone down to help improve those outcomes in that longer strategic focus. And then the final page, page 11, provides a long-term approach to reducing alcohol-related harm. And that the board will be coordinating a mapping activity associated with this as a standard agenda item at the meetings, because again, as the board, we recognise that alcohol harm in York is something that we really want to work towards reducing. So that was why we've separated that one. So therefore, we're here for the board to ask you to note and support these priorities, but also consider how these priorities outline within the wider health and wellbeing, and individual agencies can support that. Thank you.
Thank you. Thank you, Ruth. Thank you, Peter. Yeah, so some time for discussion now around supporting the priorities and, as Ruth said, considering how we can support the delivery outcomes. Anyone want to?
Having trouble hearing.
Oh,
We set
sorry.
the room round, I'm sorry. But I think it's questions, isn't it? So take
Yes.
those first.
Bob.
Thank you, Chair. Thank you, Ruth. Thank you, Peter. Yeah, I mean, obviously, I'll focus on children. Sort of, it's what I do. I think that there's a couple of things really. One, the what's the score tool. I wonder if you could outline a little bit more about what that actually is and how what the purpose of it is. And then in the report, it mentions you want to increase the number of young people provided treatment and support in their own substance misuse. I think I'd quite like to sort of get an idea of what the numbers look like. You know, it says increase, but what are they now? What do you want to get to? And then in general, really, how are we then reporting back here on those numbers? Because you come back to us in a year, say, or whatever the process is, and say, we've increased it, great, but what does that mean in numbers? So that's sort of my questions. Thanks.
Thank you. Yeah, so if we start with what's the score, that's a toolkit that's been developed by the current provider, Change, Grow, Live, as part of their young people service. And it's, I suppose, like a scratch card type card that any professional or an individual can use by themselves. It helps them think about their substance use. So it helps to indicate whether there's problematic use coming in or if there's anything. So it's a toolkit that's going to be rolled out to help professionals who may come across young people that they feel it'd be a useful thing to engage in a conversation. So teaching staff, for example, youth workers or any other organisations. So that's starting. They are using it in some areas of York at the moment, but they haven't done a full rollout, which is what we really want to try and improve. It's to start those conversations with young people in the right areas. And yep, more than happy to do more information around that anytime as well. And then as far as the numbers, so the numbers for young people were quite low at one point in treatment services and around mid-20s. And we have, it is improving and increasing to nearer 50. And the ambitions were set out nationally. We had targets that each area was to look at. And so we're getting into that. And again, it's that thing of why do we want more young people in services? And it's the thing of actually, we know there's an unmet need. They probably need specialist help and support to help move through rather than not accessing a service and what those barriers were. And again, more than happy to provide that information more regularly if that's what the board would like, or individual.
Yeah, just a supplementary to that. I think that's sort of where my question was going, because it's trying to work out where is the right number, because I think increasing is one thing, but it's almost sort of identifying, okay, well, we're seeing 20-ish people, for example, but actually there's 10 that we're missing, and that we need. So it's that bit of data that I think will be quite useful to work out. And I know that's quite a challenge because it's unmet need. So by definition, how do you know it exists? But I suppose that's where we sort of want to get. And I wonder how we compare against other areas that maybe are in a slightly more advanced position than us and maybe got a better handle on the data, you know, just sort of work out where we should be per, say, 10,000 children, for example.
Yeah, sure. I think Peter wants to.
Yeah, well, just to say, Councillor, whether I on the unmet need indicators around drugs and alcohol are all over the outcomes framework, because in pretty much every area you look at, whether it's people in drug and alcohol treatment who are receiving mental health services and support, whether it's people, adults in treatment, we know, and the Carol Black report told us that there's a real kind of almost diagnosis gap, I guess, and that is using a model projection where they will take York's population and they will look at the number of children, young people in the population and other demographic factors and give an estimated number of people you'd expect to see in treatment, and then the gap, you know, for instance, for substances for adults, the gap is around about 50%. For alcohol for adults is around about 80%. So we probably would see, you know, if we were appropriately treating people who are using alcohol in a dependent way, 4 times the number of people than we are currently. So with children, young people, it will be a similar methodology. And as Ruth said, 20 to 30 is quite significantly fewer than we would have expected to have seen in treatment services at any one time for a city of our sort of makeup.
I suppose one final one.
Okay.
Sorry. Are we dealing with the 20, say, and I know we've come up with a number of 20, but say it's 20. Are we dealing with those young people well? And is there room to take more children? I suppose that's the sort of the next question, isn't it? That actually we did increase numbers. Have we got the capacity to support?
Yeah, Yes and yes. So yeah, with the new provider, they've got a very strong team now for the children and young people support. And yes, they have got the capacity, and they are really out there now trying to drive some of those numbers up. And again, it's like Peter mentioned at the beginning, it's not holding them in service, it's giving them an early intervention, helping and supporting them to move through and hopefully then not reach our adult services as well.
I mean, I would just add, I think with the old model, children's services is something of a wing of the service. It was a small element. What we've got now is a specific children's service, the gate, and I think that's a much clearer model, much clearer offer. And I think we're in a much better place than we were perhaps this time a couple of years ago.
Thank you, Councillor Well. Shan, did you want?
And I must say, this isn't an area I know a huge amount about, and I haven't worked directly with any drug and alcohol groups for quite some time, apart from in a few little bits and pieces floating around the edges. But I think what I was really pleased to see was explicit acknowledgement of dual diagnosis as a challenge. I think there isn't a person around this table who doesn't know that's a problem. You can't get help with your alcohol use. If you don't get help for your mental health, you can't get help for your mental health unless you stop drinking, and the same with drug use and mental health. I think one of the things that I was kind of intrigued about was, and I may have missed it, but I didn't see any explicit acknowledgement around neurodiversity, self-medicating, and the potential impacts around that. And I think if we're serious about tackling drug and alcohol use, then the fact that for some people who are really struggling to find a way to cope with what's going on for them, then self-medicating feels like the way to normalise. And I don't particularly like that term, but it's where we are. There was a question mark for me about whether that could also be brought out more, whether there was more we could be doing to think about whether we're future-proofing, if this is the strategy for the next 10 years, and we have seen a massive increase around understanding, awareness and diagnosis of neurodiversity, whether it might be helpful to make some explicit links between that and sort of the health system and the drug and alcohol system in terms of improving support for those individuals and helping prevent challenging futures.
Yeah, I think that's a really interesting point, actually, and I will take it back. Next week we have our first prevention group, which is a children's and young people's group, but we'll look at prevention a bit more, and perhaps it's something we can take there. I think these priorities are for this year, so if we get more findings where we feel that we can then look at our priorities following on and maybe linking in through the mental health and looking at that. And I think it's certainly something, like you say, we are aware of. And again, the mental health isn't just dual diagnosis, it's recognising that people self-medicate without a mental health condition. Dual diagnosis on the whole, yes, there's definitely a need there, but there's all the wider population. So yeah, I can certainly take that away and mention it. Thank you.
Thank you. Councillor Runciman.
Thank you. Just to say again, it is difficult for me to hear at the centre of the room, but fortunately my phone is translating it into real words for me. I'm interested in 12.1, gender-specific pathways, because what isn't in there is the links with domestic violence. And if there aren't any links with domestic violence, I'll be absolutely astonished. And women going into prison, discharged from prison, which it does talk about, they may go back into an abusive situation again. And I want to know if there's anything going on to try and break that unfortunate cycle and help those women to get out of it and live independently away from the abuse. Thank you.
Yeah, sure. And we are doing a lot of work with my colleague Hannah Hall, who leads on the domestic abuse element and the crossover around linking our drug and alcohol service with domestic abuse and looking at the data there. Like you say, we are quite aware of those relationships that happen. So it is one, it's not a priority for this year, but it is there. It's certainly part of a wider approach around the links between domestic abuse and drug and alcohol use.
Right, so would you get a referral, say, from police or the prison service if they thought that the woman who was in the courts or going into prison had been overdosing on alcohol because of domestic abuse?
Yes.
Or is it a self-referral?
It would be a referral, I believe, but I can check. Anything from a court would be a.
Yeah, I can partially answer that as well. So if there were people who were very high risk, and I'm talking about high risk domestic abuse here, then there would be hopefully a MARAC or something in place, so all information around that person would be shared, and hopefully that would continue and has continued throughout their time in prison and reigniting that when they come out. So hopefully all that information would continue to be shared for the benefit of safeguarding these people within services. Yeah.
One last comment. This relies very heavily on data, and I hope it will come back at some point. If we go back to women being discharged from prison, we would need to know that they stay out of that situation and don't go back into hospital or prison because of alcohol abuse, because of domestic violence happening. So I hope we'll get some data back at some point. I'm sure that if we can, we will.
And I can say absolutely, Councillor Runciman, I think we can possibly take away as an action from this a couple of things, your comments around making sure that our commissioned drugs and alcohol provider and our commissioned domestic abuse provider are collaborating and talking to one another, because essentially what we're talking about here is coexisting issues where two referrals may be helpful, but they've got to be coordinated referrals in which the teams talk to one another. So we can make sure that those two things have been joined up, and then we can also possibly take as an action for the board that this next time this comes back, the board would like to see, as well as some of the sort of priorities and things we're going to do, possibly some of the data which lies behind, are we making a difference, which we can certainly incorporate into future reports.
Thank you. Sian, was it a supplementary to this one?
Very quick point was, just in case anyone's listening and wondering what a MARAC is, it's a multi-agency risk assessment conference where every agency that should be involved would be involved to discuss a high risk domestic abuse case. But I just thought if anyone's listening at home going, what's a MARAC?
Thank you.
Drop that in
Apologies,
there.
I should have made that clear. Thank you. Anya, did you?
Yeah, thank you. Really helpful to go through that. I was just wondering if any or how much work had maybe been done around attitudes and behaviours and societal sort of norms around alcohol and drug. I guess just sharing from an ICB perspective, and there's a lot more to do, but we're certainly picking up a sort of normalising in particular groups. So as an example, parents perhaps buying alcohol for children and young people to go to gatherings at houses, etc. And this sort of sense that something that is a harmful substance is perhaps not just being normalised but advocated. And I just wondered how much of that sort of was in this work, and if there is again is more to do, which I suspect is the case.
Yeah, there's a lot to do around that culturally, nationally, internationally perhaps, but from a York perspective, that's part of the focus for the young people's children and young people's group, which will happen next week, that whole prevention and around looking at some of the PSHE that's happening in schools, some of those conversations, how we can support parents with exactly what you're talking around, but also reducing stigma. So anybody who's affected by somebody else's substance use can reach out. So it's quite multifaceted around that one thing, but it's certainly on the agenda, and it's certainly something that we want to focus on. I don't know, Peter, if you've got anything else you want to add to that.
Well, just to say, I think it's education and talking is one thing about that, and it's really important. And I think we have to acknowledge that we live in a society where alcohol is still able to be pushed, particularly to children and young people, in a way which is making some companies a huge amount of money and causing a huge amount of harm. And there is something about the availability of alcohol, the accessibility of it, where you can buy it, and the advertising of it, which probably needs to shift to receive a population change in that. On the flip side of that, We do need to talk about it, particularly because we know stigma kills, and stigma about having a problem with alcohol or stigma about using substance stops people going into treatment. It stops people getting the care and the support they need. So I think public conversations are really important, but also to be aware that behind, some particularly, well, both these things, but alcohol and drugs, one is an illicit substance that makes a lot of people a lot of money and causes a lot of crime, and one is a licit substance which makes some people a lot of money, and we have to be prepared perhaps sometimes to be a bit vocal about how, particularly for children and young people, that is causing issues, and things can be done about it. Regulation can happen.
Thank you. I'd just like to ask one, I mean, there's loads of questions I could ask, but I'd like to ask really, so nitazine, synthetic opioids have been a real problem in York for the last maybe a couple of years and have contributed to a significant number of deaths. There is, this mentioned the community drug testing and the pathway for that. And I know in the past, I'm going back, that has been really complicated and it's had to be posted away outside York, and was a really tricky process that nobody was probably going to follow, because it took a long time to find out what the substances were. You then necessarily didn't have the substance anymore. So are you able to tell me how that has changed, improved in the last however long it has been?
So for an individual, the process still would be to post, if an individual wants to know, they use the loop and you can post that off. And like you say, that's quite a long process. From a nitazine and harm reduction perspective, we now have the contract with York University. It's joint with North Yorkshire Council, ourselves and the police, and it's called the NIDAP, North Yorkshire Drug Analysis Programme. And that is where we now have a much faster and quicker return on any sample that we feel. So if, for example, the police are called to an incident where there's a suspected fatal or non-fatal overdose and there's some drug paraphernalia around, at the scene, they can remove part that's not then going to be used for evidence, because that's the problem that we with the police is it's got to have not been put into an evidence bag, so it's got to be collected separately and it can be taken to the university to be tested. We had an example of it a couple of months ago, probably now, where we were concerned about an incident that had happened and we had a turnaround within 12 hours of what was in there to be able to then send out a drug alert to be able to ensure that others within the community and professionals that may be working with individuals are aware. So we have the eldest panel, which is the local drug information system, and that's where we'd come together to discuss. So it's much faster and we are able to test more samples than we have done before. But equally, there is an opportunity where if it hasn't necessarily caused severe harm, but there are some concerns around sample weight, it might wait a little bit longer, because the way that it works, the more samples on the testing machine, the cheaper it is. But we can only do limited. But yeah, if we've got a real serious concern about something or a particular incident has triggered something, we can get a very quick turnaround.
That's really, really useful to know, and that quick turnaround is so important, especially when there's a wave of drugs coming in the same, to be able to tell kind of what's what and give people the correct information. Yeah, and there's far more around nitazines that we're doing, which I can always come back and talk to people about, or any other time, but there's quite a lot that's happening around that, particularly because nitazines are not only now being found in heroin type supplies, but we are getting them into lots of other supply chains of drugs, so cocaine, vapes, various other places where it's creeping in, that we will start seeing nitazines in a wider, so there's a massive risk around that and how we're going to prevent some of that harm. Thank you. Thank you. Does anybody else have anything else they wanted to add? Councillor Colwell.
Thank you, Chair. Fantastic vision, an exciting strategy. I'm sure we all hope it is very effective and successful. I'm just wondering how far this reflects or is based on, or what experience they may be from other places, other cities that might have influenced this. And if that is the case, and if they started this journey sooner than we have here in York, how is that going? Do you have any examples of that? Or are we right at the forefront and pioneering with something that isn't happening anywhere else?
Unfortunately, we're not pioneering, but we're not too far behind. I think one thing I'll always say about York is the city size and the way that we are, that we have a way to be able to get things up and running and pull together, I think, on our partnership board quite quickly to improve things. There are lots of examples nationally, and I can probably share some rather than if there's some things around what other people have managed to achieve. And the national team have done a review around what combating drugs boards nationally have achieved, and some good examples of good pieces of practice that is constantly shared. So particularly around the nitazines and harm reduction, where good practice has taken place for the rest of us to learn from, and hopefully we pull and feed some of that through what we need in York to help improve York.
Thank you. Thank you, Ruth. Thank you, Peter. That was I think we've discussed the priorities there, and I think everyone's fully supportive of the delivery outcomes, and really, really pleased to see the inclusion of mental health and self-medication. So thank you very, very much. Okay, so now we move on to agenda item number 6, the Better Care Fund. Sarah Story is going to present this. We've got 20 minutes for this item, and that includes the question.
I doubt I'll talk for 20 minutes. Zoe Delaney, who's the lead for this piece of work, sends her apologies. She unfortunately couldn't make it this evening. So you got the B team, that's me. Sorry about that. So she's just highlighted a few key points, but there is obviously a significant amount of information in your pack from about pages 39 to 100. Including some slides at the end, which just highlight the key points. So the first key point, which is really hot off the press, is that literally in the last hour, we've just had confirmation that the plan's been approved. So we've had, so it was submitted back in March. We were awaiting the formal feedback, but we had quite a bit of informal discussion that indicated we were quite confident that we would receive approval. That has now come through. So that's really good news. Through that work with NHS England Assurance colleagues. So there's no significant changes to the schemes. However, there was some work with support from partners and colleagues through the Delivering Capacity Group and key stakeholders to understand the scheme names. It was a really good workshop back in, I think it was December. And I know some colleagues in the room today have joined in some of those conversations. So to understand what the schemes are, there were some presentations where scheme leads or team or service leads shared some really good discussion and information about the different schemes. And they were aligned with delivery, so we understand what each of those projects were delivering. And I think it was identified there were a number of schemes that were called different things, but really we're doing the same thing. So the number of schemes hasn't really reduced. It's just that they've been amalgamated under some of the BCF plan headings. So we've got the core objectives in the plan are around a shift to prevention and supporting people to live independently, safe and well. So a real focus on getting the right care to people in a timely way to support people home from hospital and straight home from hospital through our really reinforcing and refreshing the principles of home first. And we've been focusing on that hospital discharge, but also reducing admissions into residential and nursing care homes, both from the community and from hospital, which are key system, local authority and partner objectives. And they're key objectives for us for a good reason, which is that generally people prefer to live independently, safe and well in their own homes wherever possible. Nobody wants to be in hospital any longer than they need to, or in a care home if they don't need to be there. So there's some good examples of that shift to prevention, and in particular, I'm pleased to see the expansion of the Frailty Hub, which has been doing great work, a range of partners cross-sector, supporting people to avoid admissions into hospital and to make sure that people get the right support in the community. And again, that Home First model, which is doing some good work. We are seeing really encouraging signs of reductions in terms of admissions into care homes from hospital. There's been some changes to, I think I'd describe these as changes to terminology in the plan. So years ago, we used to talk about delayed transfers of care, and then more recently, that was changed to no criteria to reside. And there's a shift now to talking about people who are discharge ready. So all of that jargon is just about when people are no longer benefiting from medical care in a hospital bed. How do we make sure we get them back home as quickly as we can? But I think the change in terminology to discharge ready acknowledges that sometimes people are still in hospital because they might not be receiving medical care, but there'll be other things that need to be put in place to get the person home. And sometimes we rely on our hospital colleagues to put in place some of those things, and sometimes it's about partners. So that could be about, for example, making sure the right equipment or bed is ready for the person to go home to, the right care and support is available. Sometimes it's simple things like which family member's gone on holiday with the person's house keys in their bag. So, you know, sometimes we talk about people being medically fit. That doesn't necessarily mean we can whisk them straight home again. And we've been doing some good work to develop the multidisciplinary discharge ways of working, so that again we can understand all of the facets of need that somebody has, and who needs to do what to make sure we can get that person home and well. Excuse me. Again, not just about discharge from hospital though. So, you know, again, we've been seeking to reduce admissions into residential and nursing care homes for a really long time. We've made some progress on that in different areas across the country. It's stalled a little bit in York, particularly for older adults. So there is increased focus on the objectives, which are based on the numbers of older adults per population. So there are plans in place across system organisations over and above the BCF fund to seek to do that. And we've also got a number of associated schemes that will help with that. For example, you know, getting the right adaptation into somebody's property. And then just to note that there's not, unfortunately, not a significant increase in funding to the BCF plans nationally. Just about enough for a small uplift to those schemes that require it in terms of increased pay, you know, salaries for staff. The one area that did see a significant increase was disabled facility grant funding, which has gone up by about 13%, 12-13%, which is good news, because again that supports us with that objective of keeping people independently living in their own homes for as long as possible. That's probably all I need to say. I think the information's in the pack. If people have any questions, I will try and answer them. If I can't answer them, I'll definitely take them back for colleagues who may be able to provide the response that people are looking for. Thank you.
Thank you, Sarah. Does anyone have any questions? Councillor Runciman.
Thank you, Sarah. I've read an awful lot of BCF reports. I must say, I think this is a very good one. Much longer than usual, but very interesting. Just two questions, if I may. Page 43. I'm concerned about pay award increases to be met internally through non-BCF funding. Is that a significant amount? Is that to be concerned about or not, do you think?
For 25-26, I don't think we have all the confirmed pay awards. Well, we haven't got the pay awards confirmed yet for this year.
Right. So you can't say.
We don't know. No. Yeah.
And the other one's much more practical. It's about MoveMates. I've met people who've used MoveMates and they speak very, very highly of it. And you say the resources have been redirected to other schemes. Are they the same sort of thing, to walk with somebody, giving them some exercise and some confidence to get outside?
I don't think we've got specifically other schemes that do that. So the MoveMates is the walking buddies, people who generally volunteers who go out and get people out walking, doing exercise, as a voluntary sector organisation, not just in York but in different areas, so that they are still available for referrals. There are preventive schemes that the funding is redirected towards, but given that the overall budget hasn't gone up very significantly. It's not been possible to commission, you know, any significant amount of new services, unfortunately. Yeah.
Thank you.
Thank you.
Thank you. Anyone else have any comment? Councillor Colwick?
Thank you. Just following on from Councillor Runciman's question, the uplifts seem to be particularly small to me, and funding challenging. Bearing in mind the comments made by the public speaker at the beginning of our meeting, do you see any further concerns there?
I mean, as the Director of Adult Social Services, in every post I've held, there's always a concern about funding. We never really can allocate or receive as much funding, certainly as most of our providers, both for profit and not for profit voluntary sector providers would need. It's always a balancing act. It's always a worry in terms of have we spread it in the right places? Have we taken account of the pressures that all providers are facing? All I can say is there's, you know, a significant amount of work and effort and consultation and engagement has gone into considering each of these schemes, what funding is available, and how that's been allocated. We need to continue to review and evaluate that as we go through the year and into subsequent years. And we know that there will be continued pressures for particularly the external sector in relation to you know, changes such as the national insurance employer contributions. So we are in ongoing engagement and consultation with the majority of our providers who are reporting worries about financial constraints. You know, the funding that's been allocated nationally to BCF is what it is. We've not been able to influence that to be increased, unfortunately. The council, you know, has put significant additional funding into our budgets over and above what we've received from government. We'll need to continue to work with all of our providers, and if they have any concerns about their capacity or the pressures, we'll consider those as and when they crop up. Really, councillor, that's that. I'm sorry, I can't be more optimistic in my response.
Thank you for that response. I think it's an honest one and as diplomatic as it's possible for you to be.
Thank you, Councillor Colwick. Sian, Alison, do you?
Yeah, I agree. It's an excellent report, lots of detail and some really good examples of some great partnership working. I have said this before, so I will say it again. The VCSE doesn't get much funding via the BCF. It's tiny in comparison. And I'm not asking for handouts because, you know, it's not new money and I know that. But I think it's looking at where are the opportunities for BCS to get involved in this type of work. More than more would you do it. So that, just make that point that I think there's more potential for us to be involved to deliver on these issues.
Yeah, absolutely. Sian.
And I think my point does follow on from that, which is, again, I agree, it's an excellent report. Like Councillor Runciman, I've probably seen far too many of these and not understood most of them or glossed through a fair few. I did have a query actually regarding the largest level put in as a charity or voluntary sector contribution is the contribution to the York Carers Centre service plus direct payments for carers and home-based packages of care to facilitate carer respite. And I just was querying, does all of that funding actually go into the voluntary and community sector, or does that need to be two lines split out?
That's a detail I've not got to hand.
I imagine it's, yeah.
Would you drop me a note on it and I'll check
yeah.
on that one?
Yeah.
But partly because it's so small on my screen, I can't actually read it. But I think I know which two you're referring to, and I'll just
yes. I think in total, the ones that I'm 100% confident are voluntary sector add up to about 627,000. Right. But then there's 736,000 for carers support. And I suspect not all of that is actually voluntary and community sector. There will be a contribution to the carers centre, but I don't know where the packages of care are funded.
Right, yeah.
If that makes sense. And direct payments aren't strictly voluntary sector.
I would have to check the split in terms of carers.
No problem.
Yeah, thank you.
Thanks.
Thank you, Alison. Did you want to add to that?
Yes, so I did check this out with Care Centre earlier, actually. So I think to the VCSE, it's about 400,000 from that line. and then the rest goes to the other stuff that's in there. So it's about 400-ish.
Okay, thank you.
Well spotted, Sharon.
Okay. Okay, did anyone else want to add anything?
Sorry, while I'm
Yeah.
making really annoying nitpicky points,
Mhm.
which seems to be my raison d'etre at the moment, could we left justify all reports in future? Because they make my eyes go woogly, and if they make my eyes go woogly, there's probably other people struggling with it a bit as well.
Yeah,
So
absolutely.
everything left justified, and then it doesn't fill up the page and go funny.
I think normally that would have been picked up, but there has been an issue with the printing and the editing of the report this
No
month.
problem. I know
But
Ben's
yeah.
been working very hard behind the scenes
yeah.
to keep us all straight. So thank you for that.
Absolutely, we will pick that up though. Thank you, Sian. Okay, if there's no more comments, thank you, Sarah, for presenting this. Really, really pleased to see the shift to prevention and support for people to live independently and move from home from hospital. I think the scheme that I found most interesting within this, and I've forgotten the name, so you might have to, is where people are put in more intensive support where as soon as they're discharged from hospital to avoid, if they want to be home, avoid going into longer term, which is more costly care, but most importantly, enabling people to stay where they want to stay with the right support. So thank you very much. Okay, so if we move on to agenda item number 7, and that is goal number 1 in the joint Local Health and Wellbeing Strategy 2022 to 2032, reducing the gap in healthy life expectancy between the richest and the poorest communities in York. Peter is going to present this report, and we've got around 20 minutes, and including the presentation and discussion around this. Thank you.
Thanks very much, Chair. So my usual spiel about why we get these kind of reports. We have a health and wellbeing strategy. It's for 10 years. We have action plans, which we're essentially doing in 2-year sort of bite-sized chunks. And we've got through 2 years of an action plan and brought back last time to the board our second action plan covering the next 2 years with a number of actions associated with the 10 goals of the strategy. And now we're going to regularly bring updates on each goal, probably not each one every time. We tend to cluster them a little bit, and sometimes we discuss 1 or 2 each time. The first goal in the strategy is this overarching goal around health inequality. So actually what this report turns out to be each time is a little bit more about the data and what the evidence is telling us about health inequalities in the city. I sort of make no apologies for that in a sense, even though it does have quite a few sort of graphs and points of data in, because it's a fundamental thing we want to keep an eye on. It is also for us in City of York Council within the council plan that we regularly update and publish data on health inequalities in York to understand the progress that we are making or otherwise in tackling them. So that's what the report does. It lays out a number of things, and I will just skim over some of them and summarise. It's some similar material to last time about the definition of life expectancy and healthy life expectancy, because if those are the things that we've talked about in York that we want to make the overall difference to, they're almost our North Star that we're heading towards. It's important to know what we mean, but I won't cover that because it is laid out in the paper in terms of some of those very technical definitions. But then on the 3rd page of this particular report, there is a table which gives the most up-to-date healthy life expectancy, and the gap in life expectancy between the richest and poorest bits of our city. Some of this data is not updated to the timeliness that we might hope for, particularly around the gaps in life expectancy. So unfortunately, some of those gaps are very similar to where we've seen before, but they illustrate, for instance, some rather large over 10-year gaps, both in male and female life expectancy between certain wards in the city. The healthy life expectancy data and life expectancy data for the whole city is updated fairly promptly. So we've got 2021 to 23 data. To pull out a few things from that, one of the most concerning trends I think we're seeing is that whilst life expectancy has stopped rising, it's on a bit of a plateau. Healthy life expectancy, the number of years that you can expect to live in what's self-reported either good or very good health, has been falling. And so essentially we are seeing the number of years people live in illness increase in the city at quite a dramatic rate, actually. So over the last decade, males have lived 27 months more of their life in ill health and females 43 months. So actually quite a larger proportion of life where you're ill, possibly not able to work, possibly not able to contribute in the way you might want to society. And that there's what's described as, a huge chronic disease burden, which is really affecting Western nations. And we certainly see that played out in the data from our city. And then talking about the gap in life expectancy, whilst we don't have very helpful up-to-date data on that, what we do have is recent parliamentary constituency breakdowns, which display some of the disparity, and I wanted to draw the board's attention to that. And these aren't geographies that we've not talked about before, but York Outer and York Central constituency show really remarkable differences in their life expectancy. So for York Outer, we see a life expectancy which places it 61st out of 650 constituencies. So essentially quite near the top. People are living really quite long in York Outer. York Central, it's 541st. So actually in the bottom 20% when it comes to life expectancy, which is not usually something you'd expect to see for a city like York. So some real severities, and essentially is the wards within our city with the lowest life expectancy cluster within a particular parliamentary constituency. It's not really nothing to do with that geography per se. It's just that that's where those wards are. So I thought I'd highlight that to the board. Moving through the report, I'd also thought I'd highlight that what I've tried to do is explain the gap through a number of levels. The first level is what's actually causing people to get ill early and to die early in the city. And that's at paragraph 20, the graph which talks about, a number of reasons why people die. There are obviously, thousands of causes of death, but if we're looking at really broad groups, we still see that about 2/3 of the gap in life expectancy, so the reasons people in poorer areas are dying early, come from three predominant disease areas: cardiovascular disease, cancers, and respiratory diseases. And those types of disease, 80% of cardiovascular disease is considered preventable, 30% of cancers is considered preventable, 60% of respiratory diseases. So actually, this is an awful lot of illness that you can do something about with the right interventions. And then there are a number of, risk factors which lie behind why people may, for instance, develop something like chronic kidney disease or develop something like COPD, chronic obstructive pulmonary disease. And the top ones for York, as illustrated at point 24, are tobacco, high blood pressure, dietary risks, and high body mass index. So probably not new news for many, but those are the things which are leading to the gaps that we're seeing. And then behind that, at point 26, I try to highlight that those factors cluster in areas where there are high levels of deprivation, and also the conditions for health are not being built as effectively. And again, the data isn't as good as we might like it here and isn't as timely, but data from 2018 to 20 to point 26 just shows a number of indicators: fuel poverty, child poverty, poverty affecting older people, unemployment, overcrowding, and the prevalence of overweight and obesity in school age children, and the large, often sort of 2 to 3-fold gaps between wards in the conditions of health. The report goes on to talk a little bit about some of the things that we are doing about this. And what I've tried to do actually is to use a framework that Public Health England, rest in peace, Public Health England used, which was around civic level interventions, service-based interventions, community-based interventions, which is quite a well-established health inequalities framework. It just shows that it's not, health inequalities aren't just tackled by the public sector doing a thing. They're not just tackled by communities doing a thing, and they're not just tackled by services being rearranged. All three are needed to create the conditions for tackling health inequalities. And what I've done in the table under point 35 is just pull out some examples. And I hesitated a bit when I was doing this, because as soon as you list some examples, people will think of 10 other things that are going on which are fabulous and working in this space. So I don't want these examples to look like a comprehensive list. They are simply just examples in those three areas of a number of things that have been funded or provided by, often by the council, sometimes by the ICB, sometimes by national initiatives, sometimes delivered through the third sector and funded through charitable causes, sometimes funded through primary care and the way that primary care arranges itself. Just to illustrate some really interesting ways, often with very little resource behind them, that services are being tailored to meet the needs of often our more deprived residents, but not always about deprivation. It may be about some protected characteristics. It may be about some aspects of cohorts of individuals, for instance, those who have experience of being in the care system, those who are carers, veterans, other groups within society where we know these inequalities exist. So, for instance, we talked a little bit in the report about the Brain Health Cafe, about delivering welfare advice directly within GP services rather than expecting GPs to refer into it. We talked about some of the loneliness and cultural wellbeing activities funded for asylum seekers in the city. The Health Mela event, which is happening this Sunday between 10 and 5 in York Museum Gardens, all about cultural diversity and health and how we reach populations who might have access barriers. Some supervised toothbrushing in schools, work we do around targeting homes which are particularly vulnerable to winter and helping people with respiratory issues. You know, I could go on through the list, but you can read it yourself. Some really good examples of interventions. And then finally, I will just say that a lot of this isn't just about new money to do new things. It is about trying to reorient services. And this afternoon, I went to a really good event at the Priory Centre with both quite a lot of our primary care colleagues in the room and some from the hospital, talking about the health inequalities programme that is mentioned in the report. And it was the feedback event about what some of these professionals have been doing. And we heard about one practice that's been proactively looking at its dementia diagnosis and looking at how it can improve those rates for more deprived populations by moving diagnosis more into primary care, being able to order CT scans, for instance, directly from GPs. One practice talked about people who may be at risk of diabetes and getting their blood pressure readings in, and they focused in York particularly on the bottom 3 deciles of deprivation. They invited those patients in proactively and actually saw a huge, a 2 or 3-fold increase in the number of those patients at risk of diabetes who have had a recent blood pressure reading. It sounds really simple, but actually getting them onto the right blood pressure medication can prevent diabetes and therefore the complications. And we don't have the resource to do that for everyone in York. We're doing it for the bottom most deprived bits of the city, and actually that is going to tackle health inequalities. So none of those schemes required any investment or resource. They required looking at the resource primary care had and using it differently and targeting it. So I guess the encouragement with a paper like this is it's not simply about we don't have enough resource to tackle health inequalities in the city. We probably don't, but we can do some things differently, and we can make a difference if we think about the lens of health inequalities in the work we're doing. So I'll stop there, Chair, and we can have a discussion. Thank you.
Thank you very much. So as a board, we're being asked to comment on the current data and inequalities in life expectancy and healthy life expectancy in York, and discuss how inequalities arise and where to look for solutions. So would anybody like to speak? Councillor Webb.
Thanks, Chair. Thanks, Peter. I mean, I know I've seen the numbers several times, but 61st in one part of our city and 541st in another part. I mean, you know, we've been talking for a long time about how unequal, how much of a problem this is in York, but you can't get more stark than that, really. I mean, it's a great reason for some, you know, a great argument for progressive taxation of the most wealthy, isn't it, really? I mean, if we're talking about, we could put in proper preventative care that could support those individuals who need it most. And that, I think, would, you know, probably that preventative side would then save money in the long run. A few specific questions. I think on page 105, there's the reducing the health gap, and there's a beautiful looking graph. It's coloured and everything, between men and women. And there's some really sort of stark differences in you know, cancer difference. So the cancer sort of percentage is relatively close, but then in the male column, the external causes is 17.3, whereas for the women, that's 4.1. And then vice versa, other for women is 16%, but only 1.8% for men. And I'm just trying to get a bit of a handle on, because you talked about the main ones, obviously circulatory cancer and respiratory. But then obviously, yeah, there's a lot in those other bits. What's the detail around that?
Well, I think the other category I'd have to go and look at exactly what that contains. External causes for males, sadly, is almost exclusively death by suicide and death through substance use, which affect males to a greater extent, although I think it's fair to say that the harm from substances and attempted suicides is more evenly spread across genders, but deaths are higher in those areas. The other category is likely to contain a very large number of different causes of death, and I expect it's simply that external causes that much higher in males, if you see what I mean. It's kind of almost a proportion of the deaths, and in females there were just a wider range of causes of death, and this is this is all ages, I think. I'm right in saying,
because if you look at the male column, it's deaths under 28 days. And
what it doesn't have in there, for instance, in any of the other causes, are deaths from dementias. I don't know what that would be, possibly neurological. So that is potentially more likely to be a cause of death for women who live longer than men. But yeah, I'd have to go and understand that a little bit more. It's probably buried in a government tool somewhere, exactly what comes into each category, so I can find that.
Yeah, thank you. Am I all right to ask? Yeah. And I think that it's quite important, and I think I'm just thinking of sort of solutions, and I think it's really helpful to have had a sort of a selection of things that are happening and things that are useful. And since we've got councillors around the table, it's a council committee. We have ward funding, which I'm very pleased that this administration changed that ward funding to be based on health inequalities data in order to sort of redistribute and it is small, and I know it's small, but the money that we have to those most in need. But I wonder if there's any work we could do to take some of these examples and share that with ward councillors to say, look, whatever opportunities you can spend money on particular issues that are in your ward, and some of our outer wards, for example, it is loneliness, support for older people could be something that could be a real focus. But I know in my ward of Heworth, benefits advice is something that's really helpful, because that alleviates poverty, which is a major cause of these things. So we've got benefits advice that goes into a church group, typically serves older people. We've got a new one that we started, which is benefits advice based out of a primary school just after drop-off time in the morning. And then, if I'm honest, a lot of our money goes on providing food-based events to get people together. One, because sadly people are undernourished in some communities, and two, just to get them together so we can actually, because again, you're tackling loneliness and you get a chance to speak to people. But it's just, I think we're going to be practical. Is there any tools we can use to share with colleagues to focus what little money there is?
Yeah, I think it's a really good action to take out of this, Chair, and I can have a conversation with Pauline Stutchfield, our Director of Housing Communities, who oversees that. At the moment, my understanding is wards obviously have access to ward profiles, and there have been a number of sort of ward action plans, but the extent to which every ward in the city has an up-to-date action plan sitting there and ready, I'm not clear on. But what we can do is make sure that the health information, the provision, is highlighted in those, and like you say, share some of the best practice for some of this. And some of it is just a case of thinking about eligibility criteria for some things and being able to understand where you might target. Sometimes it's not about eligibility criteria, it's just about where you advertise the thing, where do you put up posters, and just being thoughtful about the fact that, there may be some communities within the city who aren't regularly going to the places where we put our posters up for some of this, and we need to actually be a bit more proactive about the way in which we write to kind of communicate and reach the community. So I will pick that up with Pauline Stutchfield and request that we make sure that health information and data about some of these issues and best practices part of that ward conversation.
Thank you, Peter. Councillor Runciman.
I'm interested in page 109 to 111 in particular, but I wonder, Peter, if you can estimate when we're going to see a change in the data, when these will take effect. Some of them I know, some of them have been refocused, some of them may be relatively recent, but we need to see that all of those things are having an effect. And I wonder if you can just talk about that for me.
Thanks, Councillor. Did you just quickly clarify? I'm sorry, I don't have the proper pack open. I have it just has one single paper. It's the wrong
Very
page
easy,
number.
very easy, Peter.
Do you have a paragraph?
Community-based interventions, civic level interventions and service level interventions.
So it's the list of things under.
Yeah. Okay.
Fine. Thank you. So we've done some, I mean, this is a list that's drawn from several different places and not all of these places. Oh, thank you. Yes, not all of these are public health schemes, so not as close to all of them. For the ones that we've commissioned through health inequalities money, we've had an evaluation which can be shared actually with the board of all of these and how effective or not, because some of them haven't been as effective as others. They've been at meeting the outcomes we set for them. So some of them, it's quite hard given the level of resource to nail down to very specific outcomes. I'll take, for instance, what we'll do on Sunday with the Health Mela. Last time there were 3,000 people there. We're hoping for more than that. Coming to an event where you have over sort of 30 or 40 different organisations talking about cervical screening, blood pressure monitoring, diabetes for South Asian communities, that sort of thing. All of these different things that offer outreach opportunities to talk to people about health, particularly who are coming from sort of ethnically diverse communities. It is quite hard after that to be able to say, and the result was we saw. However, I guess we follow the logic model of saying, we know that often the NHS and council services don't reach to all parts of the city. When we gather people with the offer of incredible food and brilliant culture and all the stuff that the Mela will do, and have the opportunity to talk about health, we will have a positive benefit. So sometimes we can really show progress. Sometimes we can't. There are some things in here, for instance, around hypertension diagnosis, blood pressure diagnosis, where we can actually evidence that we've seen an extra 1,000 people added to the register. The evidence shows that for adding 1,000 people to a hypertension register and getting them on a blood pressure lowering medication, you actually save 17 strokes a year, which results in 6 deaths averted. You can actually really quantify some of this stuff nicely. And we've always aimed for a mix of things that we know we necessarily can't quantify, but is very community based, and the things that is possibly more healthcare based that we can quantify, because we think that's the best sort of almost spread bet for some of this in terms of getting real impact.
Yeah, absolutely.
Health Inequalities Education Programme, Peter, the take-up of that and how effective the 30 professionals feel it is going to be.
Yeah, and again, I can share the slides from this afternoon's event, actually, which had 4 different examples, because the 4 primary care networks all participated and they each did one project. From what I saw at this afternoon's event, it's been very effective in engaging people. Particularly, those events have had a lot of lived experience input into. So the Poverty Truth Commissioners attended to give their experiences. York Travellers Trust have attended a number of different sort of events at which, particularly for sort of busy jobbing GPs who are doing clinics every day of their life, to give them the protected learning time, to take them out of that, to sit in a room for an afternoon and hear from those communities, and then big challenge to run their own projects in practice. I think it's been very effective. And what I saw of the project was some really good changes of practice, where, you know, particularly the one I mentioned around people at risk of diabetes, you can actually see in the data that practices are finding more of those patients, particularly from deprived communities. So again, those slides can be shared with the board, because it was a really interesting set of presentations. So I think there's been quite an effective educational piece. That's what it's been. It's been workshops and seminars, but that's actually what our professionals have needed in order to train them to do this stuff well.
Thank you. And I just wanted to follow on something from what Councillor Runciman said about showing the effectiveness and how these things are working in communities. And I think we all fully agree about the benefit of prevention in communities has such long-term health effects, but also I really agree about being so hard to measure. If we look at the supervised toothbrushing, you see, it might be 20 years down the line when we see the benefit from that, when somebody's got no holes in their teeth. And I think some of these have got such long reaching outcomes, but really, really positive. And I think for a lot of it, the positive is the engagement in the first place, isn't it? And getting those people involved with different projects. Yeah. Okay, did anyone else have anything else to add on that goal? Nope. Okay, so we will move on to agenda item number 8, which is the update from the York Health and Care Partnership. We have around 15 minutes for this, and Anya Haysbrook, welcome, and yes, whenever you're ready. Thank you.
Thank you, Chair. Is it okay to invite Michael to join the table as well in case of any
Absolutely, yeah.
detail, and to provide a bit of an update on one of the points in the report? So thank you, Chair. Thank you, colleagues. I'll take the paper as read. There are just a couple of points that I just want to highlight, and then if it's okay, I'd like to just give a bit of an update following the report on a couple of key items, one of which Michael will cover, and that is an update on the Section 75 and Joint Committee. And I would like to just give a brief update on the quite dynamic changes within the NHS and ICBs. I thought that might be helpful, just to provide a brief update for board members. So, as I say, I'll take the paper as read, which summarises the last 2 executive committee meetings, but I would like to particularly pull out the reference to the children's plan, which was draft at the time of being presented to the committee. That has now been approved by the Integrated Care Partnership, which we're really pleased about. That is a system approach to children and priorities around children and young people, which is really excellent, and it is already getting quite a high level of national attention. So it was featured very recently in the Centre for Young Lives report published just last month. So I think that's really testament to the strong system working, and particularly around the golden ambition of improving outcomes for children and young people. And again, I won't go into the detail, but you can see in there just the example, further example and illustration of the value of the York Population Health Hub. So those were just a couple of things I want to point out, if that's okay. I will hand to Michael in a second, but I will just give a brief update of some of the significant changes that are underway in the NHS, of which one key element covers integrated care boards, and as I touched on, it's a very sort of live, dynamic situation and very fast-paced. So you will probably remember back in March there were some rather big announcements around changes to the NHS, most notably in essence it was called the abolition of NHS England, and the move of some of those functions back into DHSC. That was in tandem with some headline announcements of a series of headline cuts to running and other costs, primarily relating to NHSE functions, but more notably with ICBs, and some to do with what is called as corporate cost growth within our providers. They were all set at a 50%, really. It was quite clear across the board. And we were then waiting for further information about what that entailed, and we received a letter from the new NHSE Executive Transformation Team led by Sir James Mackey, which again signals some of the direction for ICBs in line with the changes at NHS England. It was termed as laying the foundations for reform, and we have subsequently been waiting for some information that was termed termed as model ICB. So this was giving further, or the intention was to give further clarity of the renewed role for ICBs in that national context. So setting out in more clarity the national role, the regional role, the ICB role and the provider role. That was expected midway last week, so at the end of April. Unfortunately, because of the pre-election period, there was a slight delay, so that was actually received very late on Friday. So of course, with it being having been the bank holiday, we've been digesting and interpreting that. But there are some headlines that I'll just share with you, albeit we do need to work through the detail because a lot of it is just set out in headline terms. So for Humber and North Yorkshire ICB, we need to make a reduction to our costs of 47%. The way that it's been done at a national level is it's now based on an allocation per head of population. Our allocation per head of population is £18.76, so it's a revised allocation for Humber and North Yorkshire ICB of around 35 million. The model ICB, I guess, reconfirms or confirms some of the narrative that was being seeded. The ICBs will go back to, you could argue, being more of a strategic commissioner. So that will be the fundamental role. So it will be more around setting out the strategy to improve population health outcomes, and then commission the services and other activities to support that, rather than being involved in the delivery, which will move to providers, or move more in a more focused way to providers, and the assurance and performance will move more in the direction of the regional function, which is also being reviewed, and we are expecting a model region document to come forward that will set out more in more clarity what that will entail. So the model ICB has now landed. A number of you may have seen it. I'm very happy to share if anybody hasn't seen it. But what it does is it sets out what the centre, if you like, what NHSE and government believe are now the core functions of an ICB. It sets out a number of functions that may be adapted, retained or scaled either across an ICB area or a wider level with other ICBs. And then I think more crucially for this committee, it sets out a number of functions that are set to transfer over time, is the way that it's been described in the guidance, albeit there is no further detail in terms of what is necessarily expected around that transfer, nor are the timescales clear at this time. So we will need to work at pace through that. As I said at the outset, this is working at incredible pace, so we need to submit a plan by the end of this month for our ICB, particularly in terms of that renewed core functionality within the financial envelope that I have set out. And we will clearly be engaging with partners around that. So I will just stop there. I will just hand over to Michael before we open up, if that's okay, just to touch on the Section 75 and Joint Committee, because that's an obvious question that I think colleagues will have around, are there implications for that? So
thank you, Anya.
Thank you. So I think the bit to specifically add around the Section 75 and a joint committee is that the ICB executive steer is to very much continue to look to put those agreements in place, because that anchors a lot of the ways we still expect to work, even in light of all of those changes and or some of the detail of those changes still to be worked through, but even in light of that national strategy, that the neighbourhood working and the right thing that we're trying to do in York is still very much the right thing that we want to do. And those documents probably most importantly describe the ways we want to go about doing that. And so the push at the moment is very much to continue the work to finish those off. And just as a little bit of detail, the kind of legal teams from our respective organisations between the local authority and health met at the tail end of last week to finish off those documents. for York, and that has gone, or is going through the kind of final stages of ICB executive approval to do that. So I think that's, in light of everything that is going on, I think that will be something that's still quite positive and will anchor some of those changes more formally, even with some of the uncertainty that we've heard described there.
Thank you. Thank you, Michael. Sarah, would you like to come in? Thank you.
Thank you. I think first of all, just to say, I recognise that it's an extremely difficult and worrying time for health colleagues. Whichever way you look at it, a reduction of nearly 50% of your running costs is going to be incredibly challenging, and certainly people will be, you know, worried about service delivery, worried about how that will impact on local people, but obviously, of course, you know, potentially worried about their own roles, jobs, capacity, and so on. So we appreciate that, you know, you've received this information fairly quickly, and you've now been asked to come up with a plan for how to achieve that, which is going to be really difficult. So secondly, myself and colleagues absolutely want to support as much as possible and engage as much as possible in the plans so that we can assist you with that, but also, you know, we'd be really keen to ensure that the needs of local people, local communities are not missed in any of the shifts to, you know, to higher level regional or national functions. It's really important, I think, certainly following on from the last report, that we maintain that focus on understanding what the needs are of our local citizens and populations of all ages, and we don't lose sight of that. And we've got a number of interested colleagues and citizens, you know, some here in the room today from the voluntary sector and other organisations, but certainly a lot of our citizens who might be listening to this meeting who'll be really concerned about what that means for them. So I think it'd be really important for us to engage as much as we can and engage around the detail. I think people, it's like when we talked about the BCF schemes, if they're very high level, we don't really know what that means. People want to know, what does that mean for me? You know, will I still be able to access the same services, same health services I have done previously and in the same ways? And if not, what will that change be? So obviously there'll be a need for impact assessments and an understanding of what that, you know, what that impact will be for local populations and for individuals. And I think, you know, we've made that commitment to working together through the Section 75 agreement, but through the, you know, the meetings, the discussions, the groups that we've already got, when we certainly don't want to, you know, any recent announcement to destabilise that or to risk our ability to work in partnership, because I think that's the only way we're going to achieve the best possible outcome we can from a very difficult situation, really. So I think as soon as we've got more detail, it'd be good to see that. But you know, we're all really busy people, but we'll definitely support with those conversations as much as we can. Just a final point, Councillor asked me earlier what my worries would be about our ability to manage within reduced envelopes. I think you know, reductions across the board in a number of large organisations' budgets on top of existing, you know, very challenging pressures. You know, that ultimately all of that impacts people in York, and that's what I'm mainly concerned about, how we understand that total cumulative impact for people in York, and seek to protect people from that as much as we can. Thank you.
Thank you, Sarah. And I think within that as well, absolutely agree. It's about citizens, because we can all talk and we discuss at quite a high level, don't we, about the impacts. But I think people will, and I know we don't fully have the picture yet or how it's going to look, will want to know in very relatable terms what it means for actual health services. But yeah, thank you for that explanation. That was really, really useful. Just Alison.
Is the new chair public knowledge now?
Yes.
Okay, so I just think we should mention that we've got a new chair at the ICB, Jason Stamp, who was the VCSE collaborative chair, is now the ICB chair, which is probably positive news for the voluntary sector. Not expecting special favours from Jason, but I think clearly he understands the VCSE, which is positive. So congratulations to Jason, I think.
Thank you, Alison. Absolutely agree. Sian.
Yeah, I just wanted to echo Sarah's concerns about the people working in the ICB and the impact on them. I know this can't be an easy time for any of you, and I think that sense of, I feel like we've barely begun explaining integrated care boards to the population before we have to say, and what you don't know about, we're halving, and it's all going to happen really, really quickly. And I think there is a real concern for me about how we continue to engage the public in what our direction of travel is and how we want to take them with us on that journey at a time where actually in other health reforms where we've seen this sort of scale of change happening, a lot of your time and energy is tied up in just trying to figure out what tomorrow looks like, when what we really want to be focused on is what the next 10 years look like and how we improve the health of our population over that period. So I think I just wanted to extend some sympathy, some concern, and say, for all of us, this is something that we are going to be embroiled in for the next period of time. And we will try and, I think, maintain our focus on what better and tomorrow looks like. But tomorrow suddenly feels very, very short term rather than long term. And I wish you all very well in the coming months.
Yeah, absolutely. And I feel the anxiety for staff becomes even more when they're within this uncertainty of having to put these plans into place, but not quite understanding where the uncertainty lies within the organisation itself. Thank you. Yeah, absolutely.
Yeah, thank you. And I would really, sorry, I'd really value the kind comments made around our colleagues in the ICB. Yes, you're absolutely right. Of course, it's a very, very difficult time. And not least, let's not forget that our colleagues are also members of our communities, and there is a health and wellbeing impact with all of this as well. I did just want to come back on the really important points that Sarah made to give that assurance that absolutely the driver for this, and we might all have different views on whether it's the right thing to do, is to ensure that we are driving better outcomes for our population. That is the driver, to be really clear about the role of an ICB in driving, particularly through strategic commissioning, better outcomes through the services that are delivered. So I want to give that assurance, and absolutely partnership working, as just echoed by Michael, around the Joint Committee Section 75 continues to be absolutely fundamental and will be a fundamental thread there. So there's a strong emphasis, again, really happy to share if colleagues haven't seen, but a really strong emphasis again on population health, improving population health, addressing inequalities, all of the things that Peter has talked us through today. So whilst we haven't quite worked out the detail of how that will be done, that absolutely continues to be the ambition. But thank you again for the feedback. Peter, did you?
Thank you. Echo other comments about the sort of the human aspects of this. Probably needs to be front and centre, and certainly we enjoy really close collaboration with particularly the place team and other teams like quality and nursing in the ICB, and really want to continue that close working that Michael has described. I think the document, the model ICB, reads in a very NHS sort of way, and it's got some really quite important missing words, and I think possibly the challenge for us as a partnership is to put those words back into whatever the arrangement's in. So interestingly, and I really welcome some of the public health aspects of it. It seems quite strong there. It has the word epidemiology in, but doesn't have the word social care in, and I think that's quite an omission, really. It doesn't have the word integration in. It doesn't talk about local authorities very much at all, and place seems to be less of an emphasis. And so anything we can do, I guess, particularly for future arrangements, to incorporate those words back in locally, even if they're missing nationally in guidance, I think is the challenge for us, because I think that they are the things which probably will affect residents the most. And then from a local authority perspective, safeguarding SEND, special education needs and disabilities, and continuing healthcare are areas in the paper which have very high local authority overlap and are the most vague in terms of where they will transfer to. I think it doesn't even name a bit of the system. It says to test and evolve and potentially think about moving elsewhere. That does constitute a bit of a risk in those three areas, and do think we need to be mindful of that. Hopefully further clarity will ameliorate that risk, but those are areas where you know, you get it wrong and you really get it wrong. So I'd be very keen for us to work together to know where those three things will sit.
Thank you, Peter. Councillor Webb. Martin.
Thank you, Chair. I think it was to echo some of what Peter was saying. I think one of the challenges, I think it's not a new challenge that when something comes out nationally, that it isn't necessarily cross-departmental and recognises different pieces of legislation, the primary legislation, that means it's often quite difficult to untangle, a bit of a spider's web to sort of untangle. One of the issues certainly that I'm concerned about and will continue to worry about is obviously child safeguarding practice from a systems perspective and not necessarily just from an operational perspective. We know that each of the providers will have their own safeguarding mechanisms to keep in place, but actually it's really important that we maintain in place a really strong systems approach to safeguarding practice. So I think there's we've got to have continued conversations about what that means, but there is also primary legislation, which I think if we look at the children's school and the Children's Wellbeing in Schools Bill, which is also just going through Parliament, it actually creates a number of conditions for the health system, primarily multi-agency child protection teams and multi-agency family help in communities. So there's going to be some real challenges, I think, in terms of trying to decipher what we need to do now to get to the 47%, or and what actually needs to take time. And some of those things, particularly around child safeguarding, child protection, and safeguarding in the system, I think will take a lot of time to think about. It'd be really difficult if we drop that whilst we're trying to rush to the 47%.
Thank you. Sarah, was that a supplementary on this?
Sorry, I was just debating with myself whether to say this or not. So I absolutely agree that in our region and local authority and in our partnerships, our aim is to try and improve outcomes for people, health outcomes, through social care support and working together. But I just want to address the point you made earlier. The driver of reducing running costs by nearly 50%, of taking £35 million out, is not to improve outcomes. I think it's really unrealistic to think we can take the £35 million out of a system and that things will get better as a result, unless that money is definitely going to be reinvested back into our local system and area in different and better ways. So I appreciate that's probably not what you meant. I absolutely know that we want to try and improve outcomes for people, but I genuinely think it's unrealistic to think that you take that amount of money out of a system and things will get better. I think I think probably we need to focus on how we reduce or mitigate the risks in relation to that as much as possible. I'm not really optimistic enough to think that things will improve as a result. Sorry.
Thank you.
Thank you.
No.
Can I have a go now?
Yeah.
Cheers.
Councillor Webb.
No, I think first and foremost, changes to working conditions, changes to your employer, things like that are terrible things to go through in any situation. So I think staff, you know, so solidarity with those workers, particularly the lowest paid workers who would struggle. Following on from something Sian said earlier about bringing the public with us and teaching them about an ICB and stuff like that. I'll be honest, I'm sorry, but nobody cares. They want to know that they can get that hospital appointment. They want to know that they can get that doctor's appointment. And so what happens behind the scenes and that stuff, it is, of course, it's really important that we get that right. But I think from our point of view, from a public facing, how do we communicate this? It is got to be about, you know, how do we share what is happening and how it is benefiting or not benefiting people in the city. I think that's the bit that's really important. And so I suppose a question for me really is, how does the changes that are going to happen over a period of time, how are they communicated with this board? And I accept that there's a very short time frame around some bits of this, but obviously that you mentioned a transfer over time. So there's that process over time. So how is that change going to be communicated with this board moving forward, so that it is communicated publicly? You know, and we need to think about strategic oversight for reducing duplication where possible, clarity over what an ICB should do and how does that benefit the public. A renewed core functionality is what you mentioned. I think, again, if we can work out what that means, that's really important to bring to the table. And yeah, I think that gives us an opportunity to focus quite rightly on how do we make sure that this is helping improve health outcomes for people in the city. And I share your concerns that, you know, if you're removing something from a system, how do we make sure that that's helping? And I'm not sure if we can, but certainly having an input is really, really important. So I think, you know, let's be really frank and honest. I'm not trying to be mean, even though I'm probably sounding it. In terms of how it works, the public aren't necessarily that bothered. What they want is it is actually working. And so I think a renewed focus on what an ICB should do is important. It's an opportunity. I admit it's a terrible way of doing things. I'm sorry for that, but you know, I think it's certainly something that we need to grasp and engage with. Oh, one more point. Actually, from the report, I was going to say how welcome and how glad it is that we have got that focus on children, because I think that had been missing previously, and that's a real positive. And that's what I came in to say in the first place. And then we started a big conversation about the ICB, but thank you very much.
Sian, did you?
Yeah, I just wanted to say, I agree with you. By and large, the public are not interested in how we organise ourselves until it doesn't work and they don't understand which bit of the system isn't doing the thing it should for them, at which point our interest levels do peak quite quickly. So I think if it all works seamlessly, if we get this right, then yeah, who cares? But if it doesn't work, if there are gaps, if there are clunky bits and the system doesn't enable people to get where they need to be and find out who they're supposed to speak to get the answer they need, to get the health or care service that they desperately want, then I think that does start to become interesting for people. And I spend much more of my time than you'd think explaining the weird and wonderful ways of our health and care system to people who get very interested very fast when they can't get to where they want to.
Thank you, Sian. Councillor Runciman.
I agree with what Bob says, and there's not quite all of it, but very nearly. We've got two issues here. It's become very obvious very recently that if you take things away from people, they don't like it, and understandably so. But it's also, as Bob says, nobody knows about the ICB in the first place. So what we have to do is to find out what the ICB can do, can offer people, and promote that to help them as much as anything else, rather than saying a sort of woe is me message, because that's not going to go anywhere. And all people do when you start doing that is they say, Hannah, how does that affect me? I'm not happy about that. So I think your PR, your comms people are going to have to do some very fancy footwork, Michael, to get the message out, not about what the ICB is or does, because that's a sort of structural thing that most of the public probably won't be interested in, but actually what the ICB can commission that is good and helpful to the population of the city. Now, you probably knew that anyway, but I wanted to say it.
Thank you, Councillor Runciman. And did you want to come back on any of that, Anya, at all?
Thank you. Just very quickly, in terms of the communication to this board, absolutely that will continue, and particularly in this month we had a separate conversation around how we might start doing more of that, particularly in this coming period, and likewise as Sarah said. So absolutely I'm making a commitment to do that, and likewise if anyone wants to engage with me, very open to that. I think going back to the points that you've just made, and as I alluded to, this is setting, the ambition is to set the foundations for the 10-year plan, which I think will give more of that sort of public facing clarity around the direction for the NHS, that it does then become a little bit irrelevant. Is it the ICB? Is it a provider who's doing, because I agree with you, actually, in most cases, well, I'm agreeing with both of you, in most cases, the public don't care. They just see it as the NHS until it doesn't work, and they want to know which part it is. But I think that will be the opportunity to have the broader conversation with the public around what actually this means in terms of how things will evolve around those 3 shifts that we already are well versed in. Thank you.
Thank you, Anya. And thank you, Michael. Thank you, everyone, for that discussion as well. Time is really getting on now, and I really would like to get to the Healthwatch report. So is everyone happy to take my report as read, or has anyone got any desperate questions about it? There was just one thing I really wanted to highlight that I thought was really positive, which was the roundtable discussion with primary care and the outcome of the supplementary statements within that, which was, and the agreement that they can now be used to identify a gap in pharmacy provision. So there is a gap identified in Clifton for pharmacy provision now, and there are applications in that will be coming forward. If everyone else is happy to take the rest as read without any urgent questions, we'll move on to agenda item number 10, which is the Healthwatch York report on GP surgeries, accessibility audit findings and GP practice websites in York. Sian, I welcome you to report this, and we're asked to note the recommendation and the responses that people have should be sent to Healthwatch for inclusion in the annual report in July. Thank you, Sian.
Thank you, Chair. So some of you may remember I previously brought our interim GP report about the survey findings, and that report highlighted some access issues that had been raised by people. So these reports are basically the follow-up to that, a little bit more work we've done following that report to explore access and web access more deeply. And to be honest, this feels like something of a rare treat in that I feel like quite rightly, we have a bit of a reputation, me and my team, for rocking up and bringing the doom to the meetings, sharing what isn't working, listening to the unhappy, telling you all you need to do better, and amplifying the voices of those who are having the greatest difficulties in navigating our often amazing, but also frequently complicated health and care system. Today, I'm not doing that at all. What I'm doing is sharing our general reports on the accessibility of GP practices and websites. And I want to say there is a lot of good news in here. There are a lot of GPs who are getting this, if not 100% right, pretty close. They're doing a really good job. So I want to start with some thank yous. Thank you to my team, especially Ruth, our volunteer and engagement officer, who is currently doing what I would describe as 2 full-time jobs in a part-time role and doing them very well. She led this work, stealing with pride from Healthwatch North Yorkshire's their web access process and developing the physical access audit surveys from scratch. I want to thank York Disability Rights Forum, who sense checked our audit plans to make sure we were considering the different aspects of access. And sharing their expertise about what we needed to look out for. All our work is richer for the input of our voluntary sector colleagues, for which we are incredibly grateful. I also wanted to thank our amazing volunteer team who gave over 75 hours of their time to visit these GP practices in person and review their websites online. And my final thank you is actually to our GP practice colleagues in the city. They have responded with great enthusiasm to these reports and to the individual reports that each of them have been sent after we publish these general reports, many have already confirmed that they have made changes as a result of the general reports, and they're committed to doing more. So these reports actually just contain some simple, practical ideas for improving access to all. They're not our sweeping look at the entire scope of the health and care system, but I hope you found them really interesting. I hope you found them useful, and I look forward to hearing more about the changes they help to bring about. And I'm happy to take any questions if people have them.
Thank you, Sian. Peter.
Just to check, I presume these have been fed back to the individual practices who were audited in terms of specific recommendations.
Absolutely. Every single GP practice has received a report specific to their website and specific to each of their sites. So if it's a single practice, they've obviously just got the report about their one site, but if it's multiple sites, they've got feedback on all of them. And we even went to Pocklington because we were thinking about the whole York Health and Care Partnership additional integrated neighbourhood team. We didn't want to leave them out. So yeah, we did Pocklington as well.
Thank you. I wanted to say, yeah, really well done. Brilliant, brilliant report. What I really wanted to highlight, which has not been, is rarely highlighted, having a number of people in my family who are hearing impaired, the thing about the radios was so beneficial. And I think there are certain people who can't go certain places because of the background noise. And I think really highlighting that, I think, and we've come a long way from moving on to thinking the accessibility was just for people with physical disabilities. And I think that is really positive that is highlighted throughout that.
And I think there's more we can do now. We've seen there's been some good access tools around neurodiversity and understanding autistic friendly spaces. Now, actually, we've picked up most of those sorts of issues through the questions we were asking. But I think if we were to repeat this work, we would definitely kind of go back and check against that again. And I think, yeah, there's lots of reasons why people find access difficult. If you focus purely on physical impairments, you are missing a huge number of individuals who will struggle. And there's so much of this that is possible just by making it clear that if anyone's struggling, they can ask for help. Yeah. Doesn't cost anything to have a sign up saying, struggling, ask us, we'll help you. Yeah. So it doesn't have to all be expensive changes.
No, absolutely. Thank you. Anybody else have anything they'd like to discuss, ask? No? Martin?
It would be remiss of me not to just point out very quickly to everybody that Children's Services has been inspected. I think we mentioned it last time. But it has now got a public report that's available, and Children's Services are now regarded by Ofsted as outstanding in all areas. It's a lovely report to read, and can be found just by Googling York Ofsted, and it takes to the report. There's a lot in there as well about the partnership working across police and health, and some really positive messages around the really good partnership work in York, and some very good stuff around around health.
Thank you very much. And yeah, absolutely well done to everyone in Children's Services, and definitely have a look at that report. Okay, does anyone else want to raise anything? Nope. Okay, then thank you everybody, and that is closed. Thank you.